the folks who are here, what kind of organizations are they from?
Technology.
Okay, so I guess it's a broad group, right? So if I can start now, what I'll do is I'll just bring you through a set of slides. I mean, rather a slide deck where I've prepared a presentation for how we can approach cancer care from the first world perspective. And hopefully there'll be some bringbacks for the different organizations here in terms of how well patients, or rather well individuals, can think of cancer care for their family and loved ones. And if there are any other questions, then we can take it from there. I think that there should be at least about 15 minutes or so for Q&A, and we can go into in-depth questions if there's a need to. Okay, so let me just start. So my name is Huren, and I'm the CEO and co-founder of Oncoshot, which is a cancer collaborative platform. We are based in Singapore. I'm also a medical oncologist, and I work at the National Cancer Center, Singapore. For those of you who may not be familiar, the NCCS here is the largest national hospital for cancer care. And we also conduct the most number of clinical trials in Southeast Asia. So I'd just like to quickly give you an overview of the burden of cancer care, globally. So cancer is the second leading cause of death globally, with about 9.6 million deaths, at least in the year 2018. In the developing countries, we know that cancer may actually be the #1 leading cause of death in many countries, including Singapore. Globally, 1 out of 6 deaths is actually due to cancer. And the main drivers of death in terms of leading behavioral and risk factors include tobacco, obesity, low fruit and vegetable intake, lack of physical activity, and alcohol use. Disproportionately, it's really about tobacco use, and this accounts for approximately 25% of cancer deaths. And that's the reason why globally there's a lot of effort that's being placed in terms of smoking reduction and activities surrounding that. Late-stage cancer presentation and problems with inability for diagnosis and treatment is very common. And this is about more than 20%, especially in low-income countries, which may not even have basic facilities for pathology services, which is required for an accurate diagnosis of cancer. And more than 90% of high-income countries reported treatment services. More than 90% of high-income countries have treatment services, whereas low-income countries may have a much lower percentage of these treatment services available for them for cancer. Now, in this blue image, what I'm trying to actually show is the intensity of cancer incidence. And we can kind of have a sense that the dark blue areas are of higher incidence, and they tend to be more in the developed countries like the United States, Canada, Europe, and Australia. But when it comes to mortality, we find that the distribution changes significantly, where there's a lot of more weightage in the middle and lower income countries as well. Now, what about the burden of cancer in India? So the statistics show that there are approximately 2.25 million people who are living with the disease. When you say living with the disease, it usually means that they have either been diagnosed within the last 5 years with cancer or recently. So, for example, you may be diagnosed and then you were treated, but as long as the diagnosis happened within the last 5 years, we would say that you are living with cancer. And for most people, for them to be so-called cured, they usually require the disease. They require to be disease-free for at least about 5 years. So new cancer patients are diagnosed at a rate of about 1.1 million every year in India, and there are about 800,000 who die from cancer every year. Now, the risk of developing cancer for an average Indian before the age of 75 years is approximately 10%. And this is very important to note. And the burden of cancer is also envisioned to increase significantly as India becomes wealthier. There are changes in the dietary habits and in lifestyle as well. So from 1.1 million patients who are newly diagnosed in 2018, GlobalCan foresees that this number will be around 2 million by 2040. When you look at the commonest cancers in India, many of you would be aware about cancers such as oral cancer, lung cancer, which are typically related to the use of tobacco or smoking. In women, the distribution is quite common in terms of breast cancer being the number one in both India as well as in many other countries around the world. But we see a slight change in the demographics, with number 2 and number 3 being oral and cervical cancers. And this is something that's quite different in India compared to most other first world countries. Now, I'd just like to spend some time in sharing some important concepts in terms of how cancer evolves and what we can do at each stage of a cancer diagnosis. So broadly speaking, there are 3 categories of, in terms of the timeline of cancer development. There's this well period where a patient has no known cancer diagnosis or at least no symptoms of cancer. And then there's the early stage cancer and what we know as late stage cancer. In the well phase, typically we are thinking about how do we minimize our chances of developing cancer, and how can we minimize the risks that we would have for such development. So this boils down to being aware of causative factors and establishing good health practices to minimize the risk of cancer. So we briefly spoke about the 5 key behavioral or dietary risk factors for cancer. And so those would be important to address in the well phase for people in this group especially. The second thing, which is not something that is commonly thought of in outside the developing countries, is the risk of hereditary or what we call familial cancer. So these are typically what we call underlying genetics that drive the formation of new cancer. And we see this happening in clusters of people within a family. And the one that is most well known around the world is what we call BRCA. Some of you may be familiar with Angelina Jolie and how she was someone who did not actually have cancer, but she had the BRCA mutation because her mother had a history of breast cancer. And because they got tested, patients with underlying BRCA mutation in their genes can actually discuss options of what we call prophylactic treatment or procedures to prevent cancer from coming or occurring in their bodies. And this is something that typically involves testing a family member who has the known diagnosis of cancer. But these are the 2 main things to consider when you're well and you don't have a cancer diagnosis. For people who, so what do you think of when you come to early stage cancer? And these are the key concepts. Basically, in early stage cancer, it's about detecting the cancer early, right? And screening guidelines are very important. So every country would have its own screening guidelines, which is typically a combination of what we know internationally in terms of screening methods that work, as well as in terms of a country's own unique cancer profile. So for example, in India, where we see a high incidence of oral cancers and cervical cancers, the basic screening frameworks would usually involve a lot of broad-based, population-based approaches to screen patients for oral cancers and cervical cancer. So screening is important because at a population level, if you can detect these cancers, the idea is that you can treat them early and prevent unwanted population-based negative outcomes. The second part would be a diagnosis, where typically the oncologist or the physician in charge would do a set of investigations to arrive at a diagnosis. And then the next three boxes are what we call the treatment box. So going to the second point, early stage cancers are typically localized, and barring some specific cancer types, the idea behind early stage cancer is that we want to take it away or physically remove it or chop it off, as you would say. And this usually involves surgery as the mainstay of treatment. In some cancers, not only is there the use of surgery, but chemotherapy or the combination of chemo and radiation therapy can be used, such as in cervical or nasopharyngeal cancers. Now, what I want to highlight here is that primary treatment aside, there are two boxes that go on either side. One is what we call neoadjuvant treatment, and the other is adjuvant treatment. So neoadjuvant treatment and adjuvant treatment would be in the box of what I call some additional insurance policy, right? So we know that the primary treatment is meant to cure the cancer, but is there something additional that we can provide to the patient to improve the chances of cure over the longer run? So that's where we can give neoadjuvant treatment, where the therapy is given before the main treatment, or we can give adjuvant treatment where the therapy is given after the main treatment. Now, once this entire set of treatment is completed, then we go into a phase of what we call surveillance, where typically we are monitoring most patients for approximately 5 years to watch out for any early relapse of cancer. Now, not all cancer, when it relapses, becomes what we call an advanced or stage 4 cancer. And in fact, some cancers, even when they relapse, there's a good possibility of achieving cure if they are aggressively treated. And this is particularly true in cases of colorectal or breast cancer. Now, in late stage cancer, typically outcomes are not good. It is dependent on the type of cancer that we are dealing with, and also the extent or the volume of cancer that is involved. Some stage 4 cancers are still curable, particularly in the case of lymphoma or blood cancers. However, for the vast majority, they are not. Nevertheless, there are also specific groups of stage 4 cancers where we can aim to aggressively treat and cure these patients. And this is in the group of, for example, stage 4 colorectal cancer patients, where, for example, even if they are told that the cancer has spread to the liver and it's stage 4, sometimes with aggressive surgical management, we may even cure these patients at approximately 20% of the time. So it's actually very important to be able to understand and discuss the nuances of cancer therapy. So when you put all of these things together, I think there are a few set of basic questions a patient or caregiver must ask his primary physician or oncologist after a diagnosis of cancer. The first thing would be, what is my cancer diagnosis? You need to know what is the origin of the cancer, right? That means, is this a cancer that has originated from your colon or from your lung or from your breast? And it may have spread somewhere else, for example, because it makes a difference. How you treat it depends on the origin of the cancer. And of course, you need to know the stage. The next thing that you need to ask is, are there alternative diagnoses to be considered? This is actually a very, very important point, because many patients are wrongly diagnosed with cancer because usually the reviewing pathologist may not have sufficient experience. They may be wrongly diagnosed to have cancer in terms of, one, they actually don't have cancer and then they were told to have cancer. What is actually a lot more common is that they are told to have the wrong type of cancer. And when they are told to have the wrong type of cancer, then typically what happens is that the entire treatment paradigm shifts and the outcomes are not the best. So usually it is important, if in doubt with the underlying cancer diagnosis, that these cases are discussed because of their complexity. Now, the third question that the patient should ask is whether my cancer is curable or not. A lot of patients actually go through cancer patients without actually having an idea of whether they are aiming to achieve cure, or the treatment is merely attempting to keep things at bay. This is very important because it establishes the goals of care, and it also allows the patient and the family to be prepared for the long-term outcomes. They need to assess what their treatment options are, and particularly if the cancer is incurable, the question that they should be asking is, what is the best time to start treatment? So it is a misconception that any advanced cancer patient should have treatment started immediately. Now, in certain cases of cancer where the cancer is very slow or is very limited in terms of its spread, sometimes we may even opt to delay treatment and maintain a better quality of life for the patient, because as we all would generally understand, treatment comes with its host of side effects. And that's related to point 6, what are the potential short and long-term side effects of treatment? And the last would be, are there alternatives? And I mean alternatives, I don't just mean alternatives in terms of particular drugs, but alternatives in terms of, instead of what we call standard or approved therapies, which the doctors have in their shelves, are there any other options of developmental or innovative treatments that I, as a patient or my family member, can actually benefit from? And these are possibly the main basic questions that I would like for most of my patients to actually discuss with their oncologists. Now, so this leads me to the discussion about the role of clinical trials. So in cancer care, clinical trial evaluation is considered the second pillar of treatment options. And as I mentioned, the first being existing approved therapies. What we should know is that all new treatment strategies that may have impacted survival in cancer must go through the clinical trial process. So basically, every single treatment that your doctors can prescribe today have gone through a clinical trial process that establishes effectiveness. Yet, however, access and awareness of these clinical trial options is a major challenge around the world, right? So while we, as oncologists, go around saying that clinical trial options need to be explored, many a times we don't even know how to get access and awareness to what those clinical trial options are. And that's part of the problem that we need to solve in cancer care. Interestingly, there are more than 7,000 cancer clinical trials. In fact, the number is closer to 10,000 cancer clinical trials being conducted globally. So there's actually no shortage of clinical trials. And so it's a question of really how do we get access and awareness of these trials. Now, just as a little bit of background in terms of clinical trials, just 2 examples of individuals who have benefited from trials. Some of you may know this person here. His name is Jimmy Carter. He was, I think, the 36th president of the United States of America. Not a very successful one from what I understand. But Jimmy Carter was diagnosed with stage 4 melanoma, which is a very, very aggressive cancer. For most patients with stage 4 melanoma, and typically those with melanoma that has spread to the brain, the survival is generally in months. When Jimmy Carter was diagnosed, he being a former president, had unprecedented access to many different cancer hospitals and experts. He was well informed, he was well connected, and he was a leader was an ex-leader in the biggest or the main superpower in the world. So Jimmy Carter had access to a new innovative treatment called immunotherapy. And when he accessed the drug, he had an excellent response to treatment while on the clinical trial. So from someone who would have passed away after 6 months, Jimmy Carter still continues. He's still alive. He has had treatment for more than 5 years. And in fact, he's 96 today and still well. Jimmy Carter is doing well because he was able to access clinical trials in a timely manner. This is another example of an individual closer to home. I met this gentleman at a conference where I spoke in last year. Mr. Jirapon was actually diagnosed with chronic myeloid leukemia in the year 1999. So that's been quite a while. So when he was diagnosed with CML initially, they didn't know whether he would live beyond 1 year at that point in time. And there was a clinical trial with a drug called Gleevec that started around 1999 as well. Luckily for him, the Gleevec trial was happening in Singapore. In fact, it was happening at my cancer center, the National Cancer Center, Singapore. Mr. Jirapon came to Singapore and participated in the clinical trial, and today he's still surviving. So he's been on that treatment for more than 20 years, or close to 20 years. And in fact, clinical trials today are not just limited to patients within a particular country. Patients can actually travel and explore their options in a wider landscape. So why is it so difficult to access clinical trials? Is it for a lack of clinical trials? Definitely no. I've just told you all that there are more than 7,000 to 10,000 clinical trials happening around the world. The numbers in India are around 350. In Singapore, we have approximately 200 active clinical trials. Is it for a lack of information? Maybe. I'll explain this in further detail. But sometimes it's not about whether you have the information, but whether the information is easily readable or understandable. And that's part of the challenge as well. Not just at the level of the individual patient, but also at the level of the oncologist who needs to review clinical trial information. And the last, which is actually a more relevant question, is it for a lack of awareness? And for that, the answer is definitely yes. Despite the fact that we have all these clinical trials, the truth is not many patients or caregivers understand that clinical trials are something to be continuously explored during a cancer treatment journey. And this is part of the work that we are doing to inform and educate people about cancer clinical trials. So I'll just give you an example of how clinical trial access is being conducted today and how we envision this will change. So in this example, I have a 58-year-old lady with a newly diagnosed stage 4 breast cancer. We know that the cancer has spread to the bones and to the lungs. Aside from that, we've not done any modern genomic studies. When a doctor sees a patient like this, they would know what the standard cancer chemotherapy regimens are or the hormonal therapy regimens. On top of that, if a doctor today wants to access clinical trials, they would actually go to a website called clinicaltrials.gov, which is the national registry. They would search in terms of breast cancer. And for someone like her, maybe they might say, look, since she's a Singapore patient or an India patient, we would limit it to that country. And they would then start out with 24 or 30 or 100 clinical trials. Now, it is almost impossible, and this is why I said, with regards to information, it might be a maybe. The maybe is because it's really very hard to read through the information. You have an entire listing of anywhere between 5 to 70 requirements that the patient must meet before we can decide on whether the patient can get into a clinical trial. So what normally happens is most doctors or patients look at this screen and they say, that's more than enough. How are we changing that today? We've developed tools, and in our platform, we are able to actually build patient profiles together with our oncology partners. We can capture information about a patient's diagnosis, like the diagnosis of hormone-positive breast cancer, the stage, the age, even the prior treatment history. And what we can do on our system is that we can actually match and find the most relevant clinical trials and provide the rationale for why a trial is highly matching. And because of this system today, we are able to narrow down into the key kind of innovative therapies like immunotherapy and targeted therapies and point them towards our partner trial hospitals, such as the National Cancer Hospital. In India, we are working together with Tata Memorial Hospital as well, so that we can actually get these patients to the hospitals within a period of 1 to 2 weeks. And the hospital has the information of how many high-value clinical trials a patient may have. And this particular system is envisioned to actually help patients and oncologists bring these clinical trial options in a much more timely manner for them. So if I go back to the case of Jimmy Carter, where I told you that if he was diagnosed with stage 4 melanoma and a prognosis for 6 months was given, if you had this system of clinicaltrials.gov where you have to go through manually and sort through information, you may not even get to the point where you could identify what the best option for clinical trials is. However, with the tool that we have today, we can do that immediately, and we can in fact get you within a hospital to the key trial site within a week. So this brings me to my next point, which is getting an understanding of your cancer condition, your options for cancer treatment, and an evaluation of your clinical trial options. Typically, you might go to one oncologist who would give you an initial assessment and recommendation. But today, the general consensus is that for most cancer conditions, we should actually seek a second opinion from another oncologist. There are many reasons for this, and I'm going to share with you 3 reasons. The first reason is to at least confirm a diagnosis, which involves at least looking at the reports or the histological slides of the tumor. As I said, diagnosis might change anywhere between 10 to 15 times. And if this actually impacts your cancer treatment recommendations, if it's not something that you want to accept, and you want to be very sure about your diagnosis before you start any treatment. And the second thing would be establishing the standard of care options, where not just do you want to know what are the standard of care options you might have in a particular hospital or in your country, but you also want to know what is the standard of care globally, right? Because sometimes it takes a while for an innovative cancer treatment to actually get to a country as well, because it requires a lot of clearance of regulations and things like that. And you may be given a recommendation based on what is just available at that particular center or that country. And a second opinion from someone who is a regional or global expert outside adds some value in terms of also establishing the real standard of care options that you might have. And last but not least, of course, is establishing your clinical trial options, where not just do we want to know the clinical trial options at a hospital like National Cancer Center Singapore or Tata Memorial Hospital, we also want to know what are the options in India, or maybe the top cities of Mumbai and Delhi, at least within those areas where there are good hospitals. And if you are someone who is able to travel outside, you would want to know, okay, what are the clinical trial options in Thailand or in Singapore, for example, where we have the world's global pharmas also based in Singapore, and many of these innovative treatments are established as clinical trials in Singapore and Thailand before they move out of the world to the rest of Asia as well. So we, as a clinical trial platform, also have a group of partners that we work with very closely. They are both in India and Singapore at this point in time. They straddle across not just general oncology, but they're also what we call subdomain experts in things as wide-ranging as lymphomas, sarcomas, breast cancer, and liver cancers. So with this pool of doctors, we want to be able to provide the patients who come with us through our collaborative partners like OurHealthMate to be able to assess their options with the right experts who can assess their diagnosis and evaluate their options for standard of care treatments as well as clinical trials. So as I try to wrap up the presentation, I think when it comes to a first world approach to cancer management, we need to ask ourselves the basic 6 questions that I mentioned earlier. Second thing would be always seek a second opinion from another specialist. This should be a specialist, of course, who's very relevant to the particular cancer that a patient may have. This should ideally be a national or regional subspecialist for that cancer. And from a patient or caregiver perspective, we need to always ask ourselves, at the point of diagnosis or when there's an exploration for new treatment options, we need to ask ourselves two things. What are the standard treatment options and what are our clinical trial options? As long as we've got these 3 points covered, I think as a caregiver or as a patient, you would have done the best that you can to evaluate your entire landscape and care opportunities for your condition. So I'll stop there. And Siddharth, I'm not sure how we want to do this in terms of questions.
So I think what we've told people is that they can participate through the chat.
Okay. Are there any questions that, let me just have that chat. All right, so, yeah, okay. Okay, so we have 2 questions here. Siddharth had asked a question, how does one get to know about the clinical trial? And how does one approach the institute or doctor? And what is the India perspective? So just to go through that again, the best way for you to find out about a clinical trial is to actually ask your own oncologist about it, right? What are my clinical trial options? Now, if your oncologist is savvy enough, he might be able to look it up with a lot of challenges. If he's very savvy, he might leverage on a platform like Oncoshot, where he would, create your patient profile and be immediately able to find out the treatment options. Now, from the Indian perspective, there are some key trial sites that are conducting a lot of innovative trials. So typically what I have encountered is that a lot of the private oncologists, they tend to look towards these major trial hospitals and find out what are the relevant options within those hospitals. From a platform perspective at Oncoshot, we actually capture all that information about the entire list of clinical trials that are happening within India, for example, and we can actually share and open up that information for the oncologists and patients. So I think the main thing is that there are several ways to access clinical trial options. It really starts with just asking what my clinical trial options are. And if they are willing to explore, both patient and oncologist can do that by several tools that are currently available already. The second question is by Ruben Dinakar, which is cancer hereditary? And if yes, will it be the same type that gets passed on? So cancer is a condition that happens at the level of genes. When we mean hereditary, it actually implies that it is passed in the genes from one person to another. So hereditary cancer only accounts for a small proportion of all cancers, right? If I talk to you about some well-known hereditary syndromes like BRCA, not all cancers actually occur because it's passed from one family member to another. Many cancers also happen because of lifestyle and dietary habits, which was what I briefly described in the first few slides in my presentation. So because of our changes in lifestyle and dietary habits, there can also be gene level changes that then result in cancer. So I hope that covers, that answers your question, Ruben. So Albin Abraham has a question. In clinical trials, 50% of the patient would get placebo medicines. So are we taking a risk by participating in one? So what Albin here is describing is actually what we call a randomized controlled trial, where we assume that patients who come into a trial have to go between a standard treatment, a trial treatment, and no treatment. So the truth is, this actually does not apply across the board for cancer clinical trials. There's one context in which this happens, and that is what we call clinical trials that are being done for patients who actually have no other options. It's either that, or if they are in very early phase clinical trials where, in fact, it's between getting on the trial versus not doing anything. Now, what is good in many of the cancer trials that we have is that generally the trial strategy or drug is compared against what we call a standard treatment. So this happens because the treatment paradigm for cancer is changing very rapidly. And the doctors are not going to give or put a patient into a clinical trial when there's actually a good and effective treatment option that is available on the shelf. So what we actually look for are trials that compare the current standard treatment that is available on the shelf against a potentially better or innovative treatment option that needs to be tested in a clinical trial. So that is what the doctors who are screening and enrolling patients look out for and enroll patients into. So that actually happens in terms of the clinical trial screening process. So no, I would say it is wrong to say that clinical trials, 50% of the patients who get placebo medicines. It is highly contextualized. And even in the context of cancer, very, very few trials actually do placebo. If you're in placebo, it typically means that the trial is being tested on patients who have no other treatment options available. Now, the next question that I have by Bhumika is, at which age do we have to start diagnosis of cancer? I think that's a very broad statement. But what I would say is that when you say diagnosis, you probably mean screening. It actually depends on your own national screening guidelines. So each country has its own way of looking out for cancers. So for example, what may be relevant in the Indian context is looking up the Indian screening guidelines for breast cancer and cervical cancer for ladies. There's also guidelines for oral cancer, and they would actually recommend a particular age from which we have to start these screening processes. So it's best to check with your primary physician or your general physician on these things. So the next question by Akanksha is underlying and pre-existing medical conditions, hypertension, diabetes, and such. Do these make one more prone to cancer? Do they make someone more prone to cancer? Yeah. So, well, typically we do not consider pre-existing medical conditions like hypertension and diabetes to be really cancer-inducing, although there is some association that things like obesity, which may be also highly correlated with some of these conditions, right, as having a higher incidence of cancer. So they're kind of related in some sense. So I think that's probably something to take note of, yeah? Another question was, if someone is in a high-risk category, what tests or options are available to check proactively? Okay, so this is a question that generally, I mean, the best approach would be to actually discuss this with your primary physician. It's a very, very broad question. In fact, high risk may be due to many things. It could be due to, because of risk in the family, where you see many people within the family having a diagnosis of cancer. So if that is done, for example, then what is usually required is some sort of genetics evaluation and counseling, where the entire family is taken through very complete and thorough history taking. Some of the family members may be tested, and then they would be proactively advised on what to do to reduce their chances of having cancer. Aside from that, if you're high risk because of risk factors like smoking or poor lifestyle and dietary habits, then of course you would have to do certain lifestyle changes to improve, to reduce your chances for cancer. So the next question by Bhumika was, if a middle-class person diagnosed positive for cancer, how much cost he has to plan for further perspective, or it's a rich class person disease only? Okay, so that's kind of a hard question for me to answer, but I think in India, I've had an opportunity to visit many of the cancer hospitals there, and I can say for certain that patients do have options to treatment. I think what may be a challenge would be in terms of the newer therapies, such as immunotherapy and precision oncology. Um, so how some of the companies in India are approaching the situation is that they have introduced some of these precision oncology treatments in a generic manner because the drugs usually cost a lot. So they can still access these drugs within their own country. However, I do see that there might still be a mismatch in terms of access to especially the newer drugs, which may take a bit of time, even for the richer patients to access in some countries. Let me just screen through the questions a bit more. I can answer this question by Bhumika, which is there is a research that says that more than 70% of Indian ladies suffers from breast cancer at age of 50 plus. Well, actually, that number seems really high to me. I'm actually surprised to hear that. But maybe what's more relevant is there any common process or treatment that should be done for such diseases? Yes. So what I was actually describing quite a few times was really screening, right? So in Singapore, for example, for ladies who are more than 45 or 50 onwards, we actually conduct annual or biannual mammograms to actually attempt to pick up early breast cancer. So this is probably one of the well-known screening modalities that is offered in many countries. It may be actually wise to find out from your GP, or your general practitioner, or your company as to whether they conduct any of these screening tests for common cancers such as breast cancer. So Veena had a question: are there any clinical trials to mitigate the side effects, after effects of long-term chemo treatments? Yes, there are. So I did not actually cover this earlier, but clinical trials for cancer are not just limited to drug therapies. It can also cover anything from surgery and also just studying observational studies, as we call it, which are just looking at, treatments, steps that you might take to improve side effects or reduce your chances of side effects as well. So there are some clinical trials that I've seen in India as well, where they have actually tested a lot of combinations of supportive medication to improve side effects such as vomiting and nausea or numbness of the hands and feet that patients might encounter while on chemotherapy. So yes, there are many clinical trials that are happening that look into these things as well. So Rohit had a question. For the benefit of caregivers in this panel, can you share some general health and lifestyle pointers to manage patients during the current COVID situation? Yes, I actually had a slide for this, so let me just show that. Right. So we conducted a webinar recently in Singapore where we had several specialists from infectious diseases as well as oncologists from both the private and public sector. And I'd just like to share three big major points with regard to caregivers who are taking care of patients with cancer during this COVID situation. I think the main thing is that it boils down to there is an immediate risk if a family member with cancer comes down with COVID. The mortality rates, that means the rates of patients dying from COVID in the general population globally, it's actually in the region of somewhere between 5 to 10%. It is actually changing as well. Some countries are doing better than others. But this is the general population, and I think what is important to understand is that cancer patients, because of generally a weaker immune system, may be at higher risk for complications. So we don't want our loved one with cancer to be at risk of getting COVID, right? So what do we do? So we generally advise that patients should avoid coming out, they should stay at home, always wear a mask, and practice social distancing if you need to go outside. Social distancing in many definitions is 1 meter apart from other people. We encourage as much as 2 meters if possible. The priority, as I said, is to reduce the risk of being infected while having to manage a specific cancer condition. So COVID, the risk of COVID is in the immediate short term. That's what we know. We don't really have a lot of data in terms of the long-term complications of COVID, but we really want to avoid, our cancer patients coming down with COVID. Aside from that, you need to be in very close contact with your treating oncologist. Some patients may actually have treatment that may be slightly delayed, or they may not have very frequent follow-ups. And hence, there could be certain issues in terms of the symptoms that they are encountering and the care requirements that you might have. And we have actually, at least here in Singapore, we have set up certain procedures where our patients can contact us remotely, whether this is via phone, email, WhatsApp, or telemedicine, so that they can actually consult with us and have their concerns addressed. So if this is possible, I think you should actually look into that as a caregiver, so that you can facilitate communication with the treating oncologist as well. Yeah, so those would probably be the main advice points that I would have for people who are caring for cancer patients during COVID. Yeah, so I think there's a question by Dr. Pratibha. What lifestyle changes would you suggest are essentially required that increase proneness to cancer conditions? Any empirical studies? Yeah, so there have been many observational studies, as I mentioned, and in fact, WHO. So this also goes back to the initial first few slides that I presented. The key lifestyle factors that actually increase the risk of cancer would be things like tobacco, obesity, and we should actually be, alcohol use is actually one of the factors as well. So it's important to actually minimize our intake of such carcinogens. Exercise is important, and we generally advise that, or rather, individuals maintain a good frequency of exercise at least 2 to 3 times in a week, and that may also help them not just in terms of the cancer risk, but in general health as well. So let me just show that slide again for the benefit of those of you who might have missed that. So here it is. Yeah. So I've always believed that probably India, one of the reasons why the risk of cancer is not as bad as in other countries is also because of the larger than seen vegetarian population. And so, that probably accounts for something, I guess. So tobacco use, obesity, low fruit and vegetable intake, lack of physical activity, and alcohol use. So these are probably the main things that we need to bear in mind. So there's a question about food high on vitamin C. So I actually don't. We actually don't have. We actually don't have very strong data on high dose of vitamin C for cancer, actually. So a lot of the data that comes out for vitamin C typically tends to be very preclinical data. We've not had any randomized studies to show that if you compare two populations of patients or individuals, one who have had high exposure to vitamin C versus another who did not, that the group with vitamin C does better. No, we don't actually have such data. So I think at the end of the day, you don't need to mega dose on your vitamin C. Having a balanced diet is probably the most important thing that you can do. Mayank Roy had a question. Can regular bloating or gastric issues lead to stomach, colon cancer in longer run? If yes, are there certain symptoms which need to be monitored? So bloating and gastric issues do not lead to cancer, but sometimes they may be side effects. But having said that, the typical side effects that we look out for stomach and colon cancer may be things like, for stomach, for example, yes, bloating can be a symptom, discomfort, bleeding, or what we call signs of anemia, where you have low blood count because there's been a long-standing history of ulcer, of gastritis, and these things may over time cause cancer, stomach cancer as well. In colon cancer, typically some of the symptoms that we look out for would be, a change in bowel habits. Some patients may have constipation or diarrhea or alternating type of symptoms. There might be a change, there might be a loss of appetite or a loss of weight. Usually when we find such symptoms, we would encourage endoscopy, where they can actually evaluate the stomach for ulcers or any cancerous lesions. And similarly, we would do a colonoscopy, where we would actually do a visualization from the, what we call the cecum, all the way to the anus to look out for any tumors there. So if you have symptoms, I think the most important thing is that raise this to your general practitioner. They will understand whether these things have been very recent or long-standing. If it's something that is not going away, then there might always be a role to evaluate it for a more holistic investigation and diagnostic process. We had a comment from Mr. Sheshadri, which was, what Oncoshot does is very interesting. So there was a specific question about signet ring cell carcinoma. This is a bit detailed, but I can just share with you that today we don't do a lot of trials that are specific for a cell type. In fact, the way cancer and cancer management has evolved is that we are actually looking at cancers in terms of generally, broad diagnostic terms, whether it's breast cancer, lung cancer, liver cancer, or otherwise we go into the other end of the spectrum where we tend to go into the molecular profiles of these cancers. For example, does the cancer have a particular mutation, or is there a particular feature of this cancer that is of interest in the trial? And we might actually include patients from many different cancers who fit that profile into such clinical trials. So I think the entire landscape, for how we identify patients for suitable clinical trials is actually changing very rapidly. And more often than not, there might be something that's available. We just need to find out whether there are trials that are available for that. Mukesh Gowda asked, does gastric ulcer lead to cancer? Yes, gastric ulcers may predispose a patient to cancer. So the endoscopist usually would want to follow up with some of these ulcers to ensure that they are treated adequately. And yeah, Dr. Pratibha asked, do persistent oral infections and caries increase propensity for oral or throat cancers? Oral infections, as I understand, may have a slight predisposition to increase incidence of cancer. So it's always very important, because the concept is behind what we call chronic infections, right? And the concept of chronic infections causing cancer is actually seen in many different cancers. So if you think about that, it is very important to actually look at persistent infections and make sure that we have the right treatments to resolve them. And this is broadly speaking. Yeah. I think that's those most of the questions that I had. Sorry, so my name is Dr. Huren Sivaraj. I'm very sorry about the name that I'm using my wife's account. Is there any other questions that I can help with? Sorry, so telemedicine had a question. In clinical trials, 50% of the people will get placebo. So are we taking a risk? So I've answered that clinical trials question, right? So that's fine. Any specific indications that a person can identify that he needs to meet an oncologist specific to stomach related? So I think when you need to meet an oncologist is usually when you have a diagnosis of cancer, right? We as an oncologist really depend on the support structure of our specialist partners, be it the head and neck surgeons, the general surgeons, or the gastroenterologists. They are the ones who typically end up picking up a lot of our patients. They do the biopsies. I mean, they see a patient for a presenting symptom, they do the necessary investigations, and then they make a diagnosis. Normally, what happens is when a patient first sees an oncologist like myself, you see that patient with a form that says, I'm referring this patient to you because I did a scope, for example, and the biopsy from the stomach shows that this is a stomach cancer. And that's when we take over, and then we evaluate on the basis of like what I discussed. Do I have any reason to suspect that the diagnosis may be different? Do I need to do any additional investigations? And I try to map out all of these additional processes before I come up with treatment. So I don't actually end up seeing patients with symptoms, but I usually end up seeing patients with a diagnosis of cancer. So the most important thing from a patient from a well person or caregiver perspective is that if you are not well, always seek medical assistance early. That is very important. So the longer you do not seek assistance for a symptom that has been there, then there are chances that you may have something that's undiagnosed for a longer period of time. And what we don't want is for patients, especially who've been sitting on, for example, I've seen who've got fungating or large tumors on their body. It's very obvious, but for whatever reason, they've never sought medical help because of fear, for some example. So you really just want to get to your GP or your primary physician and get any unusual symptoms or uncommon symptoms evaluated early. Sorry, so what is the survival rate of most cancer patients post-treatment and recovery? So that's a question from Dr. Pratibha Singh. This is actually dependent on what cancers we are dealing with. So survival rates can vary. What is actually very commonly treated and well treated with good outcomes are cancers like breast cancer, colon cancer, and lung cancer. Usually, if we can diagnose any of these cancers between stage 1 to stage 3, we tend to have very good outcomes, good effective treatments. Other cancers like pancreatic cancer, gastric cancer sometimes may be a bit harder to treat. But I think the main thing is that today our treatment options are constantly changing. I've shared with you about how, in the past, melanoma patients would die within 6 months of a stage 4 diagnosis, and today they are living in terms of years. The same thing is happening for patients with lung cancer. In the past, a stage 4 lung cancer patient would not survive more than 6 to 12 months. And today I have patients who are living for more than 3 to 5 years with stage 4 lung cancer. So I think we hope to see that cancer will become a more and more increasingly chronic disease, somewhat similar to managing hypertension and diabetes. And I think that's where, that's why there's a lot of research that's going into this field. And hopefully, things will start improving faster for us as well. Right. Thanks for that.
Thank you, Doctor. It was nice to go through the whole experience of the presentation. Thank you for your time. And thank you all for the making it more interactive session.
Thank you. It's a pleasure to be here. So Siddharth, if anyone has any questions about cancer, clinical trials, or second opinions, where they want to seek advice, we are more than happy to support your partners in these corporates and OHM.
Correct. So we would be sending up a follow-up communication with all the attendees, and then if they have a question, we would be further forwarding it to you.
Sure. Yeah, that'd be great.
Thank you. Thank you all.
Yep. Thank you, everyone. Take care.